Good day, everyone. I'm Dr. Tin Mo NWE, an associate professor at RCMP Uni KL. Today, we'll explore the fascinating world of the thyroid gland, focusing on its gross anatomy and developmental origins. Understanding these foundational aspects is crucial for any aspiring medical professional. The thyroid gland plays a pivotal role in human physiology and is frequently encountered in clinical practice. We will delve into its structure, relationships, vascular and neural supply, and embryonic formation, providing a solid basis for understanding various thyroid pathologies. The thyroid gland is a vital endocrine organ, often described as butterfly or H-shaped. It's strategically positioned in the anterior neck, specifically in front of the trachea, within the anterior triangles. This gland typically comprises two distinct lobes connected by a central isthmus. In a healthy adult, it weighs approximately 25 to 40 grams, a relatively small size for an organ with such profound systemic effects. Its superficial location makes it readily palpable during physical examination, which is an important clinical skill. Delving deeper into its structure, each lobe of the thyroid gland is conical in shape, measuring about 5 centimeters in length. They extend from the oblique line of the thyroid cartilage superiorly, down to the 5th or 6th tracheal ring inferiorly. The isthmus, which connects these two lobes, is typically located across the 2nd, 3rd, and 4th tracheal rings. This precise anatomical positioning is critical for understanding its relationships with surrounding structures and for surgical considerations. An interesting anatomical variation often observed is the pyramidal lobe. This is an upward extension, usually from the isthmus, but it can also arise from either lobe. It represents a remnant of the thyroglossal duct, which we will discuss later in development. The pyramidal lobe can extend superiorly, sometimes reaching the hyoid bone, to which it may be attached by a fibrous or muscular band. Its presence and exact location are important for surgeons to note during thyroidectomies to ensure complete removal of thyroid tissue. The thyroid gland, despite its compact form, possesses distinct surfaces that define its relationships with adjacent structures. Each lobe of the gland presents three main surfaces: a lateral or superficial surface, a medial surface, and a posterior surface. Understanding these surfaces is key to comprehending the gland's anatomical connections and its vulnerability to various pathologies or surgical interventions. We will now explore the specific relations of each of these surfaces. The lateral or superficial surface of the thyroid gland is primarily covered by the infrahyoid muscles. These muscles include the sternothyroid, sternohyoid, and omohyoid muscles. These muscles form a protective layer over the gland and are important landmarks during surgical approaches to the thyroid. Their presence influences the palpation of the gland and can affect the presentation of thyroid swelling. The medial surface of the thyroid gland is intimately molded to several vital structures. It lies in close proximity to the side of the larynx and trachea anteriorly, and the pharynx and esophagus posteriorly. This close relationship means that thyroid enlargement can compress these structures, leading to symptoms like dysphagia or dyspnea. Furthermore, the upper pole of the gland is in direct contact with the inferior constrictor muscle of the pharynx, highlighting another important anatomical relationship. The posterior surface of the thyroid gland has crucial relationships. It is closely related to the carotid sheath and its contents, which include the common carotid artery, internal jugular vein, and vagus nerve. This proximity is significant during surgical dissection. Additionally, the parathyroid glands, which are vital for calcium regulation, typically lie posteriorly between the two capsules of the thyroid gland. Their delicate position makes them vulnerable during thyroid surgery, emphasizing the need for meticulous technique. The recurrent laryngeal nerves are of paramount importance in thyroid surgery due to their close proximity to the gland. The left recurrent laryngeal nerve originates from the left vagus nerve and loops around the arch of the aorta before ascending. The right recurrent laryngeal nerve also arises from the right vagus nerve but loops around the subclavian artery. Both nerves then ascend to approach the medial surface of the thyroid gland, typically lying in front of the groove between the trachea and esophagus. Injury to these nerves can result in vocal cord paralysis and hoarseness. The thyroid gland boasts a rich blood supply, reflecting its high metabolic activity. The superior thyroid artery is a major contributor, originating as a branch of the external carotid artery. It descends to pierce the pretracheal fascia, reaching the summit of the upper pole of the thyroid gland. This artery is often accompanied by the external laryngeal nerve, a branch of the superior laryngeal nerve, which is itself a branch of the vagus nerve. This close anatomical relationship is critical for surgeons to be aware of during ligation of the superior thyroid artery. The superior thyroid artery, upon reaching the upper pole of the thyroid gland, typically divides into anterior and posterior branches. The anterior branch supplies the anterior aspect of the lobe and the isthmus, while the posterior branch supplies the posterior aspect of the lobe. These branches anastomose with branches from the inferior thyroid artery, forming a rich vascular network within the gland. This extensive arterial supply ensures adequate blood flow for hormone synthesis and release. Another significant arterial supply to the thyroid gland is the inferior thyroid artery. This artery is a branch of the thyrocervical trunk, which itself arises from the first part of the subclavian artery. The inferior thyroid artery arches upwards and medially, entering the lower pole of the thyroid gland. Its relationship with the recurrent laryngeal nerve is highly variable but clinically crucial. The nerve can lie behind, in front of, or even between branches of the artery. Surgeons must meticulously identify and preserve the recurrent laryngeal nerve during ligation of the inferior thyroid artery to prevent vocal cord injury. In a small percentage of individuals, approximately 3%, an additional artery known as the thyroidea ima artery may be present. This artery typically arises from the brachiocephalic trunk, the right common carotid artery, or directly from the arch of the aorta. It ascends to supply the lower border of the isthmus, where it breaks up into its terminal branches. While not consistently present, its existence is important for surgeons to recognize, as it can be a source of significant bleeding if not identified and ligated during thyroid surgery. The venous drainage of the thyroid gland largely mirrors its arterial supply. The superior thyroid vein accompanies the superior thyroid artery and drains into the internal jugular vein. The middle thyroid vein, which is often the largest, drains directly into the internal jugular vein. The inferior thyroid veins, typically multiple, descend from the lower pole of the gland and drain into the brachiocephalic veins. These veins form a rich plexus on the surface of the gland, ensuring efficient removal of blood and hormones. The lymphatic drainage of the thyroid gland is extensive and follows the arterial supply. Lymphatics from the upper pole of each lobe typically drain to the superior group of deep cervical lymph nodes. From the inferior pole, lymph drains to the lower deep cervical lymph nodes, which are often located behind the carotid sheath near the origin of the inferior thyroid artery. Additionally, some lymphatics may drain to pretracheal and paratracheal lymph nodes. Understanding these drainage pathways is crucial for staging thyroid cancers. The thyroid gland receives both sympathetic and parasympathetic innervation, although the precise functional significance of these nerves in regulating hormone secretion is still debated. Sympathetic nerve supply primarily originates from the middle cervical ganglion, with some fibers also coming from the superior cervical ganglion. These nerves typically enter the gland along the inferior and superior thyroid arteries, respectively, and are primarily vasoconstrictors. Parasympathetic fibers are derived from the vagus nerves, but their role in thyroid function is less clear compared to their role in other organs. A common misconception regarding the thyroid gland is that it is enclosed in two distinct capsules. While it is true that the gland appears to have two layers, it's important to clarify their nature. The true capsule is actually a condensed connective tissue layer that is an integral part of the gland itself, closely adhering to its surface. The false capsule, on the other hand, is derived from the pretracheal fascia, which envelopes the gland and provides a surgical plane. This distinction is vital for understanding surgical approaches and the spread of disease. The development of the thyroid gland is a fascinating process, beginning very early in embryonic life. It originates as a median endodermal thickening in the floor of the pharynx, specifically between the first and second pharyngeal arches. This thickening forms a small outpouching known as the thyroid diverticulum. This diverticulum then elongates and descends into the neck, migrating caudally from its point of origin, which is marked by the foramen cecum at the base of the embryonic tongue. During its caudal migration from the floor of the pharynx to its definitive position in the neck, the developing thyroid gland remains connected to the tongue by a narrow epithelial canal. This canal is known as the thyroglossal duct. Normally, this duct obliterates and disappears by the 5th or 6th week of gestation. However, remnants of this duct can persist, leading to various congenital anomalies, which we will discuss shortly. The path of this duct defines the potential locations for these anomalies. As the thyroid gland descends, it also incorporates cells from the ultimobranchial bodies, which are derived from the 5th pharyngeal pouches. These ultimobranchial bodies contribute specific cells to the thyroid gland known as parafollicular cells, or C cells. These cells are distinct from the follicular cells that produce thyroid hormones. Instead, parafollicular cells are responsible for secreting calcitonin, a hormone involved in calcium homeostasis. This dual origin highlights the complex embryological development of the thyroid gland. Congenital anomalies of the thyroid gland are important to recognize. One common anomaly is the thyroglossal cyst, which results from the incomplete obliteration of the thyroglossal duct. These cysts can be located anywhere along the migratory pathway of the thyroid gland, from the foramen cecum at the base of the tongue down to the thyroid gland itself. They are almost always found in or near the midline of the neck. Clinically, they present as a painless, mobile mass that often moves with protrusion of the tongue. Beyond thyroglossal cysts, other congenital anomalies of the thyroid gland exist. Ectopic thyroid gland refers to the presence of thyroid tissue in locations other than its normal anatomical position, such as the base of the tongue, lingual thyroid, or within the mediastinum. Accessory thyroid gland tissue describes additional, separate nodules of thyroid tissue. Agenesis of the thyroid gland, though rare, is the complete absence of the gland, leading to severe congenital hypothyroidism. Congenital hypothyroidism, often due to dysgenesis, requires early diagnosis and treatment to prevent developmental delays. The applied anatomy of the thyroid gland is highly relevant in clinical practice. Thyroid diseases are common, with conditions like simple goiter often endemic in iodine-deficient regions. Thyroid surgery is a frequent procedure for conditions such as nodular and toxic goiter. Due to the gland's abundant blood supply, meticulous surgical technique is essential to prevent profuse bleeding. Furthermore, the close relationship of the recurrent laryngeal nerves and parathyroid glands means that injury during surgery can lead to hoarseness of voice or tetany, respectively. Aberrant thyroid tissue, like lingual or mediastinal thyroid, represents ectopic tissue that can also become diseased. Goiter refers to any abnormal enlargement of the thyroid gland. It is a common clinical presentation and can be caused by various factors, including iodine deficiency, autoimmune diseases like Hashimoto's thyroiditis or Graves' disease, and benign or malignant nodules. While some goiters may be asymptomatic, larger ones can cause compressive symptoms such as difficulty swallowing, breathing, or speaking due to their close anatomical relationships with the trachea and esophagus. Understanding the underlying cause of goiter is crucial for appropriate management. Thank you for your attention and participation in this session on the gross anatomy and development of the thyroid gland. I hope this detailed overview has provided you with a solid foundation for understanding this vital endocrine organ. Should you have any questions, please feel free to ask.